All right, well, welcome back. Thank you guys so much. I hope you all had a wonderful lunch. We are looking forward to some fantastic afternoon sessions. So without further ado, I will pass it over to Lissa Poincenot that will bring us into our scientific panel. Thank you, Lissa.
Welcome again. This session is devoted to LHON Science issues. I'll provide updates in several areas related to LHON, including therapeutics development, handouts, data insights, and recent medical literature. If you go to the session in your app for this, you'll find PowerPoints. So if you can't see the screen, we've tried to optimize it for low vision, so that might help you follow along rather than trying to see the screen. After I review those issues, we'll have two speakers, each sharing their insights and experiences caring for LHON families for many years. And if there's time for Q&A at the end, we'll do it, but I suspect our talks will take the entire session. But there is a half-hour break following the session, and you'll be able to come up to any of us individually for questions. The first therapeutics development update, and all of these updates are the best I can offer based on a non-scientific expert reviewing the literature and the publicly available information. Things change, so things may be different from what you see here. I'm doing my best to synthesize information that I see out there, but I learn new things every day, as we all do. So just understand that this is the best that I can provide for now, and it may be different tomorrow. It may have changed since we made the slides. The first update I wanted to talk about concerns Raxone, which is made by Santhera, a Swiss company. Raxone's the pharmaceutical grade of idebenone, which is a synthetic form of CoQ10. Their studies have included patients with all three of the most common LHON mutations, 11778, 14484, and 3460, up to 5 years post-onset of vision loss. Raxone received conditional approval by the EMA, which is the European version of the FDA, back in 2015, and they were asked to do some additional post-launch study. They undertook a study called LHON, and that study was completed in 2021. They enrolled 199 patients, and I think 181 are in the study reports. Those patients were in the US and Europe. And unlike the prior RODOS trial, which was placebo-controlled, this study had no placebo. Those treated were compared to a natural history cohort. And unlike the earlier RODOS trial, which only lasted 6 months, the LHON study lasted 24 months. Results from this trial have been discussed at various conferences, but have not yet published, and we're eager to see the full details. And we can assume that the consensus guidelines that were constructed after the RODOS trial will probably be updated if the data suggests any changes to what's currently recommended. This highlights one subset of participants they examined closely, and those are individuals who began treatment less than a year after onset. The study confirmed what was suspected after the 6-month RODOS trial done many years ago, that taking the product longer led to more improvement in more participants, with some who eventually responded to the treatment not responding until 24 months of treatment. And the treated group did somewhat better than the untreated natural history cohort after 24 months. Next, there's been a lot of effort by a company called GenSight, they're a French company, on a gene therapy product for just the 11778 mutation called Lumivoq. A corrected copy of the 11778 mutation is injected into one or both eyes. All of GenSight's trials have focused on people affected within a year of onset of vision loss. On September 15th of 2020, GenSight submitted an application to the EMA, and while they've been waiting for that approval, some individuals have received treatment on an early access program. In November of 2021, they experienced a production issue in validation batches for the EMA approval process, which slowed down the EMA process, and when their supply ran out, they could no longer provide product on the early access programs. But that problem was corrected in September of 2022. They've published many articles on the safety and efficacy results of their trials. They published an article on a non-human primate study on the contralateral eye after unilateral injection, and also some studies on indirect comparison of Lumevoq versus natural history. On April 19th of 2023, they met with the EMA, and the following day they withdrew their application to the EMA. So in terms of next steps, they haven't fully articulated what those will be. There had been talk of doing another clinical trial, this time with a true placebo arm, but that's currently uncertain if that will happen. And they are assessing whether or not to resubmit to the EMA. Looking at their most recent trial, Reflect, they did show some improvement versus baseline and versus nadir, which was sustained from 18 months to years 2 and 3. Turning now to a company called Neuroth, a Chinese company. They've also been working on gene therapy for LHON. They've conducted several investigator studies in China, then initiated a phase 1-2-3 clinical trial also in China. They enrolled 102 individuals who had been affected 6 months to 10 years post-onset, ages 12 to 75. They used a sham injection as placebo, and enrollment for that is complete. On clinicaltrials.gov, you can currently see that there's a US phase 1-2 clinical trial that reports as not currently enrolling. They don't list the locations yet. 18 patients will be enrolled, affected 6 months to 12 years post-onset, ages 18 to 75, all with the 11778 mutation and no placebo. One could imagine that if that goes well, they would do a phase 3 clinical trial here in the US, which would be likely to have a placebo arm. Neuroth has also been working on a gene therapy for the 3460 mutation. In China, they've done some studies with a small number of patients, no placebo. Again, on clinicaltrials.gov, there's a phase 1-2 trial posted, again with no locations listed, with a total of 18 patients to be enrolled 6 months to 10 years post-onset, ages 18 to 75, no placebo, and planned to begin later this year. And again, one would assume that if their phase 1-2 trial goes well, they would likely move forward to a phase 3, which would again likely have a placebo arm. Neuroth has been raising their visibility and awareness of LHON by conducting webinars with key opinion leaders around the world twice a year. Recently, I participated in a webinar with 4 US neuro-ophthalmologists, including folks many of you know, Dr. Nancy Newman, Dr. Mark Moster, Dr. Prem Subramanian, and Dr. Joyce Liao, as well as doctors from Asia and a patient representative from Argentina. Turning in a different direction, at our last 2 conferences, we've had talks from Dr. Ann Chiaramello, and last year with her collaborator, Dr. Andrea Grotman. And they are in DC, and they became interested in LHON Plus several years ago, thanks to outreach by Lissa Thompson, someone many of you know, who leads our LHON Plus community. And Dr. Chiaramello has been investigating LHON Plus deeply. She received a Department of Defense Discovery Award, and she's also received an NIH NCATS UH3 clinical grant. It was a basket trial grant situation, and so she proposed a therapeutic intervention for 2 indications, MELAS and LHON Plus, and she just this week was very pleased to complete the 2-year process required to submit the IRB to the FDA. And if that goes well, then the intent would be to conduct a phase 1 clinical trial where they would assess safety, determine maximum tolerated dose, and evaluate potential for efficacy by gathering evidence during a 12-month study. Several folks in the community have shared info about their non-ocular symptoms and participated in her initial work preparing to submit to the FDA. Another topic in the world of therapeutic development is mitochondrial donation. We haven't really talked about it at any conferences recently, but it's been in the news lately, so I wanted to bring it up. It's an IVF procedure which uses mitochondria from a donor woman without any mitochondrial mutations, and the nuclear genetic material from a mom with a mitochondrial mutation and the dad. In the US, back in 2017, the Institute of Medicine produced a report on mitochondrial donation at the request of Congress. They recommended the federal government allow clinical investigation and application, but for male embryos only, so as not to impact the germline. Funding to institutions that do it is banned, so this technique is not being pursued now in the US. The UK government came to a different conclusion after their ethics debate in 2015. They allowed the procedure to be studied at one site, Newcastle, where the first license was granted in 2017. There's been renewed attention on the process in the media as it was announced that the first baby has been born using this technique. The article says the data has been submitted for publication, so we should know a lot more when that happens. In Australia, the government approved testing of the procedure in late 2022, and this year Monash University has been named as the site for their clinical trial. Turning away from therapeutic developments and onto LHON handouts. Since our last conference, we've created 2 new handouts on topics of interest to the community. One is called LHON and cardiac issues. And again, these handouts are in the section of your app called Family Handouts. And there's 5 handouts there. 2 are new this year. One is called LHON and cardiac issues. There's uncertainty, lack of 100% agreement about whether or not cardiac issues are a thing for people with an LHON mutation. But cardiac issues are a thing for many people with many mitochondrial diseases. So we gathered information about the research that might associate cardiac issues to LHON or to mitochondrial disease in general, and created this handout with links to the articles that anyone who is a carrier, cited or not cited, to provide to their doctor so that the doctor can assess the situation and your personal situation and make a recommendation whether or not testing is appropriate for that individual. Another handout is about vitamin B12 deficiency. Many folks in the community have heard or think there may be something to do with a B12 deficiency and LHON. Again, there's not consensus on the topic. There was a recent large study that showed that for those under age 65, population prevalence for deficiency for B12 was 6%, while among LHON mutation carriers, 20% had the deficiency. So this handout simply recaps the topic, include links to that and other key articles, and anyone with the mutation may print it out, discuss it with their own physician, and make a decision whether it's appropriate to check the person's level or not be concerned. While we're talking about LHON handouts, I included in the handout section of the app 3 handouts that have been discussed at prior conferences. The first is LHON and Charles-Bonnet syndrome, which people may or may not be familiar with, but we had a talk about this last year where some individuals see images inside of their scotoma that are not really there. And so this handout recaps some of the literature on it and links to it. And there's a YouTube video from last year's talk. And Paul Laurie, could you stand up, Paul, real quick? Sorry, didn't warn you. So Paul Laurie participated in that talk last year and also has led a Zoom event on it where we had a lot of folks on there going, oh, you saw that? Oh, I see this. And he also does personal consultations. So catch him at the break if you're like, wait a minute, something in my scotoma, let's talk, he's your guy. Another handout is about migraine. And again, there's lack of conviction around the topic of whether or not there's an association between an LHON mutation and migraine. In any case, there are a lot of people in this community that report it, talk about it, also outside this community, which is why the correlation issue is unclear. However, again, we do have a handout on the topic with literature and a lot of links to where one can go to learn more about migraine and what one might wish to do about migraine, again, whether it is because of or just coincidental to LHON. The third handout is a checklist for LHON carriers. It's kind of like your Girl Scout Be Prepared document. Some of us in the room have had the experience of having more than one family member affected. And the good news about having a second person affected is that you know the pathway to getting medical support, and you also know what you wish you had available, or or that you're glad you have. And having gone through that experience myself a few years ago, I collaborated with Molly Garone, and we created this handout as a gift to the community that anyone who is a carrier and is going, have I done everything I could to be prepared? Here's a little checklist, and it's also something to give to your maternal relatives so that they can be prepared if they choose. Another area I wanted to just touch on briefly is some data insights. Back in 2020, a paper was published that presented the demographic data of over 1,500 individuals affected by LHON with their gender and age of onset. And now the data is even more robust, with over 2,100 individuals reported. The additional data supports a key finding of the original report, that 25% of those affected by LHON are female, which is not what a lot of people have heard over the years, but it's an accurate percentage with a very large sample size. And I think because so many data sets out there are so small, it's been hard to really separate male from female and see the differences. But with over 2,000 individuals, it is very clear that for males ages 12 to 26, there's a very strong peak in onset. It can absolutely happen at any age, but there is a dramatic peak in onset in males in the teens and the early 20s, whereas with females, there's really no comparable peak. If you're trying to identify a peak, you kind of have to say, well, ages 16 to 52, that's not a peak, that's a plateau. So it's different. But I mean, the message remains clear. You're never too young nor too old. Women, male, everyone's who carries the mutation is at risk. The last area I wanted to touch on is some of the medical literature. In prior years, you may have heard discussion about our science team. We meet monthly to read and discuss articles about LHON, working to advance our collective understanding. I wanted to highlight just a few of the more interesting articles discussed in the past year. First is an article that describes the risk of onset in unaffected LHON carriers. You may recall that during our 2021 virtual conference, Dr. Isabel Lopez Sanchez reported results of a large study in Australia, which brought into question the conventional wisdom that males who carry an LHON mutation have a 50% chance of onset. Their work made very clear that among known LHON families, where at least one person is affected, the risk of onset is more like 17% in a male carrier, not 50. Going one step further, this article, called Low Disease Risk and Penetrance in LHON, shows that even that figure of 17% risk in every unaffected male is far too high, because it's only looking at families where someone has been affected by LHON. So there's significant sampling bias. When genetic testing is done broadly in the population, not just in families where someone has become affected, it's clear that the percentage is far lower still. Next, this case study looked at an individual who had a 34-year interval between his first and second eye becoming affected. Clearly, this is an extremely rare case, as about 95% of those affected lose vision in both eyes in the first year, and most often both in the initial 3 months. The point is that before genetic testing was widely available, it was easier for someone to be misdiagnosed for so long. In this case, the patient smoked, and because he didn't know the cause of his vision loss, he wasn't counseled to stop smoking, yet doing so may have preserved his second eye. And maternal relatives could have received genetic counseling. Finally, this article about childhood onset LHON looked at 68 children with onset less than age 12. Those with onset under age 9 had a much better visual outcome than those with onset at 9 to 12. And it pointed out that childhood onset often differs from teen and adult onset. It's not the typical bilateral, subacute, real quick onset. And there are many with just one eye affected. Many are diagnosed with strabismus, which is something that most of us in the LH1 community don't even know anything about. So if we are mothers or parents of a child who's likely carrying an LH1 mutation and we hear about strabismus, we might not even connect that to having the LH1 mutation, but this article says it's something we should learn more about. It also talks about how many children are diagnosed with something called functional vision loss, and that just sounds so benign, but what it really means is that the doctor thinks you're not really blind, which is a really troubling thing for a child to hear, and we might hear more about that later. And it also brought forward that some families with childhood onset had multiple children with childhood onset. So overall, I think there's a lot more to be learned in childhood onset cases. That wraps up what I wanted to cover in the scientific session, the scientific summary. Our next speaker is a pediatric neuro-ophthalmologist, currently an associate professor at Duke University in Durham, North Carolina. She went to medical school and did her ophthalmology residency at American University of Beirut in Lebanon, then moved to Duke for her pediatric and neuro-ophthalmology fellowships. She's been on faculty at Duke University since 2009. She's interested in optic nerve head and retina development and imaging in pediatric neuro-ophthalmology. Most of her research has been in describing the use of imaging technologies for pediatric optic nerve diseases. She has a special interest in genetic optic neuropathies, including LHON, because the central scotomas caused by LHON can have a higher impact on function than predicted by the ophthalmologic examination, which can impact function, visual development, and educational goals. For fun, she likes to go on long walks and hikes and take photographs. Please welcome Dr. Mace Dairi.
Hello, thank you for having me here. So I'm going to be talking about more practical aspects from the side of a doctor, and I'll try to explain it in a way to tell you how your doctor is thinking, and hopefully later you can ask me questions. So I'm going to give out two cases. So the first one is a 55-year-old woman who came in with bilateral painless vision loss since 1 week. So 1 week she's lost vision in the right eye, and 3 months prior she had lost vision in the left eye. And your doctor is going to be asking all of these questions to any of you who comes in with this or coming in with a family member like this. So we look at past medical history, surgical history, ocular histories, and she has a family history of macular degeneration, but that didn't look like what she had on her exam. She was been a smoker in the past and has accumulated 10 years of smoking. Her husband passed away a year ago, and she's been upset about that. And she's been drinking more alcohol since her husband died. So we have for each age group, we have a checklist of things we need to make sure to narrow down our diagnosis. So we're looking for pain on eye movement because we're looking for optic neuritis, because her presentation looks a lot like an inflammation in the optic nerve called optic neuritis. At the age of 55, we're looking for a vasculitis called GCA. So we ask about certain symptoms of headaches or poor blood flow to the jaw. We asked about tick bites, cat scratches, major travels, if she consumes homemade alcohol because it can have methanol in it. And we ask about her diet, if she's vegan, vegetarian, if she's restrictive food eater. And she follows up with a primary care doctor. She's never been anemic or diabetic. So then once we've asked those questions, we start examining the patient. And on exam, we do the vision kind of two ways sometimes, and sometimes we see patients and we check their vision and it's very, very poor, and then they can look around things and they can see better, and that's called paracentral fixation. So coming in, she was already looking around things, so she's paracentrally fixating to see. Her pupils reacted very well, which usually when you have optic nerve disease, one of the telltales is there's optic nerve disease is the pupils don't react well. LHON is an exception. It's one of the reasons people can miss LHON early on. Her eye pressure was fine, her eye movements were fine, and her fields of vision were completely fine. So we look at her with the microscope, so we're looking at problems with the lenses, problems with the macula, problem with the optic nerve, and the optic nerves looked slightly abnormal. The right optic nerve looked like it was a little too pink, too red. We called it hyperemic, like it has too much blood flow to it. And the left optic nerve looked pale, which tells us there has been damage to that nerve more than 4 weeks ago. Then in the clinic, we do some testing. So the first test we like to do is something called a visual field. So a visual field is this machine, and I'm pretty sure many of you have seen it or have seen it with family members, whereby they have to sit in this very boring machine. They put their chin and forehead, and the machine shows them a central target, and they have to click a button whenever they see a light. It is a very boring test, but it actually helps us delineate the function, and it helps us assist the patient and follow up on the disease. So the outcome from a visual field is a map that looks like this one. So if we look at this map, you can see that the white part is the parts that the patient could see, and the black parts are the parts that the patient couldn't see. So we can see that the patient has blind spots in both eyes, and they are kind of in a central vision. And when somebody has blind spots in both eyes that match over each other, sometimes the brain starts releasing information because it's not getting new information, so it starts releasing old information, and that old information can come in the form of hallucinations. And that's what Dr. Poincenot was talking about, the Charles Bonnet phenomenon that's in your handout. And this is important to know because sometimes that hallucination can make sense and the patient thinks that they saw stuff while they actually couldn't, and they will describe something called a variable vision. So the visual significance of a visual field that looks like the one I just showed you, so this is a picture of a bird, and you can imagine somebody has a blind spot right in the center, and for you to see the bird, you have to kind of look around the blind spot. And depending on the severity of the disease, the blind spot can actually be bigger. So moving on to the next part of the exam, so we're looking in the back of the eye, and I told you about the right nerve looked a little too pink, and the left nerve looked a little too white, meaning right nerve is having too much blood flow, or it's inflamed, or it's active right now, and the left one has suffered an injury that is no longer active, but it's now pale. So the next test that we like to do is called the OCT. So that's the one whereby your doctor scans your retina and your optic nerve and gets the different layers of the retina and the optic nerve. And that test in particular tells us a lot of information. So first part of the test is a number that correlates with how healthy is the optic nerve and how much of the cells are viable. So the first part of the test is called the retinal nerve fiber layer. So we use this test a lot in glaucoma or anybody with optic nerve disease. And the number is supposed to be between 90 and 110. So if it's lower than that, then we know there's something called optic atrophy. When it's too low, then it's optic atrophy that has a lot of damage. And when it's somewhere in between, that's an optic atrophy that may be active right now and has promises to recover later. As a matter of fact, there's studies that show that people who have LHON, who lost vision, if the number on the retinal nerve fiber layer is higher than 50 or 60, they actually have a higher rate of recovery. Then the next test we do is the same OCT scan, but it's now looking at the macula. And at the macula, we look at a layer called the ganglion cell layer, which tells us how many of the cells in the retina are actually viable. And that number is even more accurate than the retinal nerve fiber layer number, because that tells us how many of the cells are viable. So if that number is healthy, that's promising that damage is not completely done yet. So for our patient, who we still don't know that she has LHON, but she does because I'm telling you about her. The reason I'm telling you about her is I just want to show you how much testing she's had until we figured out she's had LHON. Like, it's kind of the least common thing to think about when a 55-year-old comes in with this type of vision loss. So we checked her blood for inflammatory markers that were fine. We checked her for syphilis, that was fine. We got an MRI looking for optic neuritis, which is an inflammation in the optic nerve, which can look a lot like LHON. That was fine. And the other thing we checked her for B12 deficiency, folate deficiency, heavy metal toxicity, that was fine. And that was the syphilis test, we already did it. So eventually, after all of this testing was negative, so we've taken a good 6-8 weeks, and we got the genetic optic neuropathy, which goes to the lab and comes back in another 6 to 8 weeks, and then she comes out to have the 1778 mutation. So she carries a diagnosis of LHON. So we know that LHON is a genetic mitochondrial disorder. The most common mutations are the 11778, followed by 14484, followed by the 3460, and there are other mutations out there that can look exactly like it. Patients present with a bilateral acute or subacute central vision loss, and the carriers of the gene may be normal until a stressor activates the gene. Typical age for presentation is 15 to 30 in boys, and apparently a little older in women. But it can present at any age. As a matter of fact, our patient is 55. And we have specific eye findings, like they tell you in the books, you have to look for these eye findings. They don't apply to everybody. As a matter of fact, the majority of the time they don't apply. So anyway, you have what we call a pseudodisc edema. The nerve is red, and if you try to see if it's uptaking more fluid, so you do something called a fluorescein angiogram, it doesn't leak, so we call it pseudo-swelling rather than true swelling because there's not an active inflammation there. And sometimes patient can have like a signature vessel that curves in a funny way that we call a telangiectatic vessel, but like more than 60% are not going to have it. The prognosis for visual recovery is not very good, and so there's the debate about the EKG, but it's a cheap test to do, so we do send our patients to get an EKG and make sure it's fine. And the treatment that is most appropriate in this day and age is going to be idebenone. The gene therapy is still being investigated. Whatever we came back from the results is not as promising as we thought it would be. So when we say mitochondrial optic neuropathy, it's a little difficult to understand because the way we see the world is there's a map from the retina that gives us the peripheral world. And the cells in the retina, each one of them has a different anatomy, and each one of them has a different function. It's very much like the fingers on your digits. Each one of them does something different. So there are the cells that are in the center of the macula that have a different anatomy to them, and they are very highly mitochondrial dependent. And these are the cells that are involved in LHON. So basically, you're involving these cells most of the time, and that's why you get this central scotoma. So the papillomacular bundle cells, so these are the cells that I just showed you in the picture, they are different from the rest of the retinal ganglion cell. They are skinnier, and they have a lot more synapses. Synapses are connections between neurons. So when you have these synapses, they can actually sum up the information at higher speed and more efficiency. So we want these synapses in the center of our vision because they actually give us details. So these same cells that are skinnier, they're richer in mitochondria, they have a lot more connections. They're like a busy bee that's very connected to everybody and does a really good job. And these are the cells that can't work when they're affected by LHON. So there are a lot of other diseases that can give us a mitochondrial optic neuropathy. The common ones are nutritional optic neuropathies, so B12, folate, heavy metals, vitamin A deficiency, or heavy metal toxicity. There are certain medications that can actually harm these same cells regardless of having that gene, like ethambutol or linezolid. So the treatments that have been tried, Dr. Poincenot has gone over all of them. So you've all heard about coenzyme Q. It's been used for a wide range of mitochondrial disorder, but other than one mitochondrial disease called primary CoQ10 deficiency, it doesn't work very well because it doesn't go through the blood-brain barrier. So it doesn't go from the blood inside the brain. Idebenone, because it does the same thing, it's a metabolite of it, because it has a shorter side chain, it can go inside the brain, that's why it's useful. But there have been other confounds that have been tried over the years, but each one of them had a very short-lived hype because it didn't work as well. So EPI 743, cyclosporine was thought to be anti-apoptosis. Brimonidine, it's a glaucoma eye drop, thought to be a neuroprotector. All of these things have been tried. Other considerations that are being studied, ketogenic diet is thought to make your body make more mitochondria and make you protected. There is a mechanism called mitochondrial biogenesis, which is a physiological process in which the cells can increase the mass and the number of their mitochondria, allowing greater energy production. And there is a thought that the patients who are carriers of LHON may have this process going on naturally, but we don't know how to induce it ourselves. But the more important is going to be avoiding triggers, and so avoiding alcohol, smoking, including inhaled smoke from the environment. So of my patients who have this, I tell them, don't go doing barbecues, don't go to bonfires. And avoiding the medications that might induce the symptoms. Ethambutol, linezolid, tetracyclines have been listed, erythromycin, streptomycin, chloramphenicol, lactated ringer. And I was in shock to see that cyanocobalamin is actually on that list. I wasn't aware of it. Because of the history of the B12 deficiency that you saw. So this is like, don't assume that, if I to take B12 to make your mitochondria healthier, because apparently it can trigger it. So don't take B12 unless you're deficient. So other theoretical considerations. So Dr. Gospi is actually my partner at the Duke Eye Center. He was supposed to be here, but he couldn't. So he has a mouse model, and he's doing experiments on the mouse. So he gives LHON to the mice, and I mean, he created a genetic knockoff of the mice, giving them LHON. And he actually puts them in a chamber whereby he decreases the oxygen level. So he gives them continuous hypoxia. And he found that it reduces the degeneration. So he has a theory, don't apply it yet before he has more results, that maybe if people who live at higher altitude may be more protected, but the main message right now is live in a clean environment. There's another theory that Dr. Gospi also tried to work on for a while. So it's coming from this investigator called Pisoni, is that he thought that the estrogens that bind some of the retinal ganglion cell receptors can reduce the apoptosis in LHON, and that's why women who may manifest it are more likely to be postmenopausal. So there's the joke that Dr. Gospi, my colleague, makes is that he wants to feminize the optic nerve, which I'm all for. I took this from a paper, so basically these are in vitro studies, so they're cells, they're not animals or humans, and they gave the cells mitochondrial stimulators. So they gave CoQ10, CoQ1, CoQ10, and I forgot what this one is, DQ and idebenone. And what they found out is it's not as easy as experimenting with any mitochondrial stimulator, because some of them can actually cause damage. So what they found out is the CoQ1 actually was harmful. So there's a lot of studies for other factors that need to be done. So for our patient, we gave her idebenone, which is the analog of coenzyme 10 that we talked about. So it acts as a transporter in the electron transport chain in the mitochondria, and thus increases the production of the ATP. And there have been studies that show there's a trend towards visual improvement. And early treatment has the best benefit. And the fact that her retinal nerve fiber layer, that number I showed you on the OCT, was actually in the 60s, was actually beneficial for her. So if you see her visual field, she recovered pretty nicely. I was actually pretty pleasantly surprised. And that's the other eye. So next is, how about the family member? So she's a woman who had a daughter and has grandchildren, so they all have this disease. So somebody's going to ask, why not give idebenone to everybody? There was a study in mice whereby they gave idebenone on healthy mice, not LHON mice. And they found that there's an adverse impact on the retinal ganglion cell morphology and visual function. So there is if somebody's not active, if you give them the idabenone, you can make them active, so don't mess with that. There's another study that actually looked at they followed carriers over time, and they found out that, right before they're going to become active, you can actually see some changes in the anatomy on the OCT scans that I just showed you. This one, they're doing OCTA scans, whereby they're doing a scan of the blood vessels of the retina. And they found out that a few months before somebody manifests the disease, this can actually become active. So based on this, what I've been doing, so this is my personal approach, it's not evidence-based, I will see the asymptomatic family members once a year, and I will obtain a visual field and an OCT. And if I see changes that are consistent that person may become active over time, then we discuss maybe starting idabenone. And of the patients that have started idabenone, they didn't become symptomatic, but I don't have enough data to say this is a large scale. So I thought the 2 talks are not going to happen back to back, but this is the second talk. So the other thing I wanted to talk about, because I'm a pediatric ophthalmologist and I'm dual trained, but I care a lot about the kids. There is something that happens in my world that makes me a little angry. So I'm going to tell you another story. So this is a 6-year-old girl. She was referred for decreased vision bilaterally. And the referring physician measured the vision as 2200 in either eye. And there's a note by the technician saying that the child saw 20/80 because they started the vision by starting from the bottom of the chart. So functional vision loss is when somebody can't see because it's like an anxiety reaction, like a conversion reaction, or somebody who's malingering. So there's 2 categories. They're either malingering on purpose, or their anxiety makes them not see. So as a trained neuro-ophthalmologist, and a lot of patients with LHON are going to be seeing neuro-ophthalmologists, so we're all trained like that. We have a big chapter of our training about functional vision loss, and everybody lies. So we need to push the patient to see better, because anxiety and social factors may be contributing to worse vision measured. And so we start from the bottom of the chart to say how much the patient can really see. And so a lot of your doctors may be trained that way. So functional or non-organic vision loss, the vision cannot be explained by the objective findings on the exam. And the usual cause is psychiatric, although actually if you put them in a functional MRI, you can see there's a problem in the center of the brain that is called the amygdala. It's connected to fear and memory. So these people have a different problem. Anyway, why am I bringing this up? The large majority of my pediatric patients with LHON were initially sent to me because someone else were giving them the diagnosis of functional visual impairment. I've even had family members in my office telling me about their child. He or she sees what he or she wants to see. They can do well on the video games, but they don't like to do homework. And it's heartbreaking. Anyway, so if we go to our basic physiology, ocular physiology book, I took this sentence out of our basic ocular physiology book. So remember that papillomacular bundle that gets affected in LHON? So it's connected to all of these other cells, and there's a lot of connections. So the layer that's right below the ganglion cell layer is the connections between the ganglion cells and the rest of the retina. And there is synaptic interaction between the inhibitory amacrine cells and the bipolar cells that makes the retina actually have a level of vision processing that we make an assumption is only happening in the brain. So in somebody with partial optic atrophy and essential scotoma, there's an attenuation in that first part of the retina that's sending the information to the brain. So the brain can intermittently compensate for it depending on the level of fatigue and the environment they're seeing. And that's why we can get a variable vision. So going back to our patient with the central scotoma, so this is, I thought the 2 talks are not happening back to back. But anyway, remember there's that blind spot that can become bigger or smaller. What I tell my patients is I try to simulate the vision, what I tell the parents. So I try to simulate the vision to the parents by I take stickers, tape, and I put it on my patients, on the parents' glasses. and I tell them this is what your child sees. So if you look around the sticker, you can briefly see something. You can see enough details. You can actually walk around without bumping into walls, but that's not good enough vision for them to be operating at anything or going to school or learning. So this can be really, really tiring. And in schools, or at least in North Carolina, that's the rule in schools, is that they will get a reading chart and they will have the patient read for literally 10 seconds. If they can read the 20/80 line, they say, oh, you don't need a visual impairment teacher. So other considerations of function, and this is important. So I can't find a lot of studies about central scotomas in optic nerve disease, but there's a lot in macular disease. So when patients are referred to low vision rehabilitation, they're aware that their vision is blurry, but they're not aware that they actually have a central scotoma. So they cannot really express it that I have a blind spot in the center. Patients with central scotoma, as I said, the large majority of them, unless the scotoma is large or it has patchy vision in the periphery, they can navigate without bumping into things. A lot of them can walk without a cane, and they don't need to feel for things. They can grab what they want without having to feel for it. And a lot of times they actually will look at their interlocutor's face, and some of them can even recognize facial expressions. So that's why a lot of people may not believe that they actually have a severe visual impairment. Sunglasses and a cane, a lot of times people in movies, if they want to show somebody who is blind, they will put them in sunglasses and a cane. So the LHON patients, the large majority, don't need a cane, and if you give them sunglasses, you'll actually kill them because it degrades the quality of the vision. You already have optic atrophy, you cannot give them something dark on top. If you want to wear sunglasses, you need them to be polarized and a really good optical polarization. So the sunglasses and a cane does not happen in an LHON population. So the role of the physician and the family member is to make sure that the school and the work environment are optimized for the need, make sure that the colleagues and teacher don't assume they're faking or exaggerating, and simulate the vision using the tape, tell them this is what they see, and ask for a visual impairment teacher, even though your pediatric eye doctor may say, oh no, the vision's 20/40, they're fine. Ask for a visual impairment teacher, because that 20/40 is a 20/40 for 2 seconds. It's not a 20/40 that's constant. So rehabilitation methods, and I saw this today from multiple people here. Screens. Patients with optic atrophy, they crave bright light and they crave contrast. So I will see the kid grab a phone and put it right in front of their eye. So this can damage the cornea, so let's not do that. We need to work with a low vision clinic. Screens are supposed to be at arm's length. And if you're gonna use the screen momentarily very close to the face, you need to make sure that you match it with artificial tears or lubrication to the cornea. I tell my patients to make the screen larger or the font larger. So if there's something you cannot see, you make it larger. You don't make it brighter. You don't get closer. So make it larger and stay away from it. And fix the setup to avoid glare. So if there is, if the patient's or the child's school desk is next to a window that's glaring in front of them, that needs to be adjusted. Contrast. Testing contrast sensitivity is not typically routinely performed in an ophthalmology office, and that's done in a low vision clinic. So if you see that chart here, you can see that the size of the letter is not decreasing, but the brightness of the letter, the contrast of the letter is decreasing. So this is how a low vision clinic will test contrast. The implication for that, like one common thing teachers will do is if they're handing out material, they'll photocopy, and then you'll get something that's very faded. You cannot do that for kids with a central scotoma. For adults, driving or walking around at dusk or dawn is actually the hardest, because at night you have the bright lights, in the day you have everything bright, but dusk and dawn are actually the hardest. So the management is you teach the patient to eccentrically view. If they are successful at eccentrically viewing, you still need to give them more time for a task, and that's very important to let their work environment and their school environment know. Using magnifiers or telescope, again, no matter how good they are, we have to remember that they take longer to use them than other people. Using audio books. Braille doesn't work as well in LHON in my experience because the vision has to be a lot poorer for the brain to pick up Braille. So when the fingertips are making up for the eyes, it's actually using the occipital lobe. So if the occipital lobe can see anything, the fingertips won't work. And with that, I say thank you. I'll take questions later.
That was absolutely fascinating. Thank you, Dr. Dairi. Thank you. Our final speaker is a professor of metabolism and nutrition at McMaster University in Canada. His areas of interest are nutritional and exercise interventions to enhance muscle function in response to neuromuscular, neurometabolic disorders, and in the aging process. Dr. Mark Tarnoposky has been caring for LHON families in Canada for many years now, and we're very interested to hear what he has to share with us.
Thanks very much for the kind introduction. I'm actually a neurologist, but not a metabolism. I'm a metabolism specialist, but not a nutritionist. All right, good. So I'm a professor of pediatrics at McMaster University, but I trained in adult neurology as well, so I treat adult patients at McMaster. I focus mostly on metabolic and genetic disorders, and mitochondrial disease is my main area of interest. From a disclosure perspective, just you can see here, I've given several talks to folks over the years, so we have to disclose those. The one relevant disclosure is that I am the founder and CEO of Exerkine Corporation. So Exerkine Corporation, we're looking at developing a sort of a biopharmaceutical approach to treating metabolic disorders by identifying proteins that go up in your blood in response to exercise. We filed a few patents on that. It does improve mitochondrial function. We're a long ways away from therapeutic interventions there, but our nutritional division is called Stay Above Nutrition. Stay Above Nutrition has taken advantage of what we've learned from mitochondrial patients, and we are using this to treat common diseases like fatty liver disease, obesity, and diabetes. We may develop some therapies that are of relevance to mitochondrial disease. However, there is no profit to our company. Anything related to muscular dystrophy or to mitochondrial disease, we have discount codes, and we are giving back a proportion to Mito Canada, so there will be no profit whatsoever. Just so people are aware of that there's no conflict of interest from that perspective. It's all about giving back to the community, which I've been part of for over 30 years. So my objectives, I'm just very briefly going to go through mitochondrial biology, and I know you all have learned this in the past. You've seen talks on this, but I'll just give you my perspective, and some of you may be new to this, so I'll just go through a very brief overview of mitochondria. And the reason I do that is that it sort of sets the stage for some of my theories and practical experience treating patients. I'm going to talk about the features of mitochondrial disease, and we've heard a nice talk about Leber's in particular, so I knew that was coming, so I didn't get into any of the deep details, and I certainly don't have the expertise in the eye physiology and anatomy that we just heard from this wonderful talk. So from a treatment perspective, I'm going to go through the rationale behind therapy, because about 20 years ago, we put forth the hypothesis that treating multiple final common pathways was more effective than just treating one pathway, and I'll tell you about that. What have we and others tried for treating mitochondrial disease? I'll talk a little bit about risk factors for Leber's. We've heard it in the two previous talks, and much of what I say sort of supports that, and I agree with that, and I'll tell you how we practically approach that. And then I'll talk about nutraceutical therapeutics in mitochondrial disease, and then sort of putting it all together. So what are the mitochondria? The mitochondria were thought to be a bacteria that invaded our cells about 1.4 to 2 billion years ago. It's a little blurry way back then because that was a long time ago. And it was felt that what's called a proto-eukaryotic cell, so an early cell took on this bacteria. In exchange for residence, we call that a symbiotic relationship. The bacteria that came in, which became our mitochondria, provided energy to the cell as the Earth's environment at the time was increasing the proportion of oxygen. What's interesting is that to build a mitochondria, it takes somewhere between 1,200 and 1,300 gene products. What's really cool is that through this 2 billion years of evolution, all of the genetic code that encodes for the vast majority of our mitochondria reside in the nucleus. The nucleus is the brain of your cell. You get chromosomes from your mom, chromosomes from your dad, and most of what's needed to build a mitochondria actually comes from the nucleus. But the mitochondria retain this tiny vestige of their early heritage as a bacteria. There's this little circular chunk of DNA That little circular chunk makes 38 specific either proteins, RNA, and transfer RNAs for the cell. So it really makes up the core of the mitochondria, which I'll show you in a minute. And it's actually in the mitochondrial DNA where most of the mutations exist for Leber's hereditary optic neuropathy. But I'll tell you about a recessive form that we've been hypothesizing for years and was recently discovered. What's interesting about the mitochondrial DNA is that if you take the person beside you and you sequence your mitochondrial genome, the differences in your mitochondrial genome will allow you to trace back when you shared a common mom, because the mitochondria come from moms to all of their children. And we've been able to, through Doug Wallace's great work, trace back the heritage or evolution of Homo sapiens to about 220,000 years ago in South Africa. What's interesting about the mitochondrial DNA, which gets to therapy, is that it's mostly what are called exons. So exons are the coding regions of genes. Introns are a chunk that's in between, which does contain some regulatory elements. It used to be called junk DNA, but it's about 100 times larger. But the part that codes for your DNA is actually your exons, and most of the mitochondrial DNA are exons. And for that reason, if you have light, and we'll talk about that a little bit later, or damage from smoke, it's more likely going to hit a coding region. And that's why the mitochondrial DNA are very prone to mutagenesis, and they have very inefficient repair mechanisms. So what do mitochondria do? Well, this is a depiction of sort of the engine or the core part of the mitochondria, and that's to make energy. So from the lunch that you all just had, essentially what we do is we take that food apart. We call that decarboxylation. The potential energy in our food is used to make these things called reducing equivalents. Essentially, it's a form of energy that's delivered to our mitochondria at complex 1, which is where essentially every mitochondrial encoded subunit that causes Leber's is in that complex 1 region. Those potential energy is really electrons. So the electrons are given to complex 1, and they flow through an elaborate series that goes to CoQ10, which we'll hear about a little bit later, onto complex 3 and onto complex 4. At complex 4, the oxygen that you breathe gets reduced to water. So those electrons eventually reduce oxygen to water. And what happens is that that energy, very much like water flowing down from the top of a river through a turbine at the bottom to get that potential energy flows back through complex 5 so we can generate what's called ATP, and that's the energy for our cells. So in diseases like Leber's, where complex 1 is affected, right at the beginning, you're not flowing the electrons, so eventually you'll end up with decreased energy supply. And that's what causes the catastrophic loss of energy and the rapid clinical features of centrocecal visual loss, which happen quickly. However, the mitochondria have another function, well, many other functions. One of them is called apoptosis. So apoptosis is called pre-programmed cell death. So when a mitochondria is dysfunctional, it releases these compounds which activate pre-programmed cell death. And that's part of the reason why things happen so quickly when people lose vision in Leber's, is it's not just the decreased energy, but then when those cells don't work, poof, they send out signals, you get programmed cell death, and that further causes damage. What contributes to human aging, because everyone in this room, whether you have Leber's or not, does have mitochondrial disease, and that's called aging. So all of us will be developing mitochondrial deletions. We're going to get dysfunctional mitochondria as we get older, and that can lead to telomere shortening. You've probably heard of telomeres. It's the end cap of your chromosomes. The shorter they get, essentially your cells stop replicating. The other interesting thing is Dr. Dairi and I just had a nice chat about inflammation. Many people, not many, but some people with Leber's, during the acute visual loss, when they come in, we don't know what's going on, and so we do MRI scans, and we can sometimes see that there appears to be a lot of inflammation going on in the optic nerve. And that's not surprising that some people have inflammation, because when the mitochondria don't work, they release these things called DAMPs. DAMPs activate inflammation. So things like interleukin-1 beta, interleukin-18 are all markers of inflammation that's going on. So in the acute phase, we were just having an interesting discussion. When someone comes in, it's probably not a bad thing that we give them some steroids, because at the beginning, when someone comes in with visual loss, we're usually thinking of more common things like MS or other inflammation disorders. And then finally, one of the things that happens, which is really then the target of most therapies, is we activate oxidative stress. So essentially, oxidative stress are unpaired electrons. So those electrons, which form the basis of life, that's what's coming from our food, really, to ultimately give us energy. If they're not functioning in the right place and they're not being captured, they will make these things called free radicals, which will damage DNA, it'll damage protein, and it'll damage lipids. So all of these processes are going on when mitochondria don't work. So when we think about treating mitochondrial disease, it's not one process that we want to target. We're trying to target as many processes as we can. So mitochondrial disease, traditionally, and again, I'm sure you're very familiar with this, traditionally it referred to disorders that affect the electron transport chain. Leber's was one of the first mitochondrial diseases that was first discovered by Dr. Wallace. That was back in 1988, where he found the 11778 mutation, which is responsible for LHON. At the same time, large-scale deletions were discovered for Kern-Sayer syndrome and point mutations at position 3243 for MELAS syndrome. We now know that there's well over 200 different mutations. And when you think about Leber's, there's the big three that we just heard about, but there's well over 20 mitochondrial DNA mutations, and we're now discovering recessive mutations. So why is it that the eye is affected? Well, the eye, as we've heard, various parts of the eye are very enriched with mitochondria. They receive and demand a lot of energy, and since mitochondria are very important for energy derivation, they're often affected. So that's why we as neurologists tend to see people with things like droopy eyelids or ptosis, optic atrophy, eyes that don't move, that's called ophthalmoparesis, seizures, strokes. But other tissues such as skeletal muscle are very enriched in mitochondria. So sometimes the weakness and the fatigue that people get is overwhelmed by the fact that you've gone blind, and people forget that skeletal muscle is also affected. But many of our patients do have exercise intolerance. In children in particular, the heart is affected, and we just heard that there's a bit of controversy as to whether the heart's affected with Leber's or not. Whether it is or not, the protection for your eye will provide some protection for the heart. So classically in adults, we've used acronyms to describe all of these different disorders. Chronic progressive external ophthalmoplegia, or CPO is the short form, and so on and so forth as we go through all of them. So we know now that at least 1 in about 5,000 people are born with a mitochondrial disorder. Whether you manifest or not, especially with Leber's, is dependent on a number of environmental factors, which we're going to talk about. If we actually look at point mutations by sequencing genes, if we do what's called deep sequencing, we can see that a large number of people have very low level of mitochondrial mutations. And this is really a conundrum now with deep sequencing. We get kids who come in with nonspecific symptoms. They get their DNA sequenced, and they have 2% MELAS in their genome analysis, which means absolutely nothing. But it's a bit of a challenge for us. So about 1 in 200 people will have some low level of mitochondrial DNA mutations. But when we look at all of the disorders that we see in the clinic, CPO, or Kern-Sayer syndrome, is the most common that's reported, but Leber's is the second most common. And certainly in our clinic, it is the second most common mitochondrial disease that we see in the clinic. So I won't spend too much time on this because you've already heard a little bit about this. Of course, Leber's is a painless, and that was emphasized in our previous talk, centrocecal visual loss. Usually it starts in one eye, but very rapidly spreads to the other eye. And pretty much every one of our 100 and plus boys that we've seen usually starts in one eye, but usually within hours to weeks, the other eye will go. But there can be a long delay between the first and the second eye going. There may be some recovery, and we're going to show you what that proportion is. And we heard earlier that there can be recovery. Men are more affected than women. About 20 years ago at a UMDF meeting, I proposed that it was estrogen, and everyone laughed at me and said, oh, it's no, some other genetic reason. But sure, the Italian group has proven that it is actually estrogen that is the factor. Thank you very much. But it does get to treatment because, for years, women going through menopause have been told that they shouldn't take hormone replacement therapy. But just 2 weeks ago, you're probably aware that there's new guidelines that have come out that the risk from hormone replacement therapy is less. But if you're a female, as we saw with the incidence between men and women, there's that little blip that went up from around age 40 to around age 55 for women to increase the risk for developing symptoms of LHON. And what's going on at that time? Ding, 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 you're dropping your estrogen, right? So it's menopause. So I think especially women who are at risk, they may be thinking that this is another thing that may tick them towards thinking about hormone replacement therapy, of course, if you don't have a family history of breast or uterine cancer. And then, as I mentioned, there are 3 variants which account for about 90%, of our patients, but there's at least 20 other mutations. So as I mentioned before, what happens when the mitochondria don't work? So let's say you have a mutation in complex 1, those electrons back up, we produce these things. Geez, this is sensitive, sorry about that. we produce these things called free radicals, or reactive oxygen species. And the problem with those is that they can go and damage DNA, they can damage protein, they can damage lipids, and cause further damage. And that's where most of the therapeutic targets have been aimed at. However, if you have a mutation in complex 1, you can try and bypass complex 1. So you can try and provide reducing equivalents through to complex 2. And that's where the ketogenic diet comes in. I wouldn't recommend it at this point, but that strategy with ketogenic diet gives you more reducing equivalents at complex 2. Other strategies, things like riboflavin, can help to increase reducing equivalents to complex 2 to bypass a complex 1 defect, which most LHON patients will have a complex 1 defect. And CoQ10 and idebenone, essentially they can accept electrons from complex 1, so it can provide you with a bypass strategy as well. And I'll just show you here. So essentially, as I've mentioned before, fat, protein, and carbohydrates give you these reducing equivalents which come to complex 1. And sorry for those of you with low vision, this was a really nice slide from Daryl Neufer, which shows what happens. So at rest, we have a little bit of leak of these protons that go from the intermembrane space to the matrix of the mitochondria. When we start eating or exercising, what happens? You can see here at complex 1, I don't know if you can see that little E grabbing onto the positive. Those are electrons flowing. So when we start exercising and we're eating, the electrons are flowing. And you can see how the electron grabs onto that little green thing going back and forth. That's coenzyme Q10. It's shuttling these electrons onto complex 3. And then those electrons are eventually going to that blue thing at the end. That's complex 4, where essentially we are now. We're exercising, and you can see that the protons that were pumped to the intermembrane space are flowing down through complex 5 to produce energy. However, even in normal metabolism, we make free radicals, but that gets worse if you have a mutation, especially in complex 1. So those bright little things, that O2 and the H2O2, those are free radicals, and they increase if we have dysfunction at complex 1. So what are your treatment strategies? I'll finish off with the most important part of my talk, and that is, how do we deal with this? What can we do? Well, the first thing I think is avoiding stressors. We know that extremes of heat or cold can increase the flux through the mitochondria. Shivering, for example, if you get very cold, increases energy demand. So avoiding too much heat, too much cold is one thing. Dehydration also is something to avoid, especially when you have a heat wave down here. Make sure that people are well hydrated. Dehydration increases the work of the mitochondria. Prolonged fasting. So generally we recommend that people graze as opposed to starve themselves. There's a bit of a controversy that you probably heard about activating autophagy by doing intermittent fasting. I think at this point for mitochondrial patients, I would probably not consider doing that. I think the evidence would be best to have frequent smaller meals and avoid prolonged fasting. Coming from me, this seems strange. Avoid excessive exercise. Every person in this room, I don't care if you're an athlete or not, if you push yourself too hard, you can cause rhabdomyolysis or damage. So you have to listen to your body. You have to gradually adapt to exercise, and it is definitely beneficial. Tanya Tavasalo, Doug Turnbull, and others have clearly shown the benefits of exercise at the muscle level. We and others have shown that there are multi-systemic benefits from exercise, including the eyes. We actually have a study we haven't published yet where we showed that older adults doing weight training actually improved their low contrast vision, which was kind of interesting. Hopefully we'll publish that pretty soon, which might have implications for Liebers as well. The second thing here is check your sleep. So even today, when I was doing the Ask the Doc, most people came in and they all had crappy sleep. What's wrong with sleep, and how does it relate to mitochondria? We know that when you're in stage 3 and stage 4 sleep, we activate these things called clock genes, which directly tie into mitochondria. So poor sleep will indirectly affect your mitochondria and cause secondary mitochondrial dysfunction. So if you have poor sleep, get a sleep study, see a sleep specialist, and consider things like melatonin, which also has some CNS or antioxidant protection effects. Finally, check and treat deficiencies. We've already heard and we're alluding to some of the deficiencies that can be seen. Iron deficiency, we generally recommend that ferritin should be over 50. So ferritin is your iron stores. Some people don't treat iron deficiency until you become anemic. However, the mitochondria have iron sulfur clusters, so we recommend keeping your ferritin up over 50. Vitamin D in Canada, 13% of our patients are rickets range severely deficient in vitamin D. 85% are not meeting current Canadian US guidelines. Certainly that rickets range is not good for you, and we've seen patients actually get rhabdomyolysis from severe vitamin D deficiency. So it's easy to check for, and we recommend trying to keep that up over 75. Vitamin B12. In our clinic, 13% of the patients that we measured are B12 deficient, and we heard that up to 15% of Leber's patients are B12 deficient. Again, I talked to some neurology colleagues, and they say, oh, well, Mark, that's not real neurology. Are you kidding me? Vitamin B12 deficiency can cause dementia, it can cause corticospinal tract involvement, and it can cause peripheral neuropathy. Does that sound like neurology to you? Yep. Does it sound like a bad thing if you've already got those issues? Yep. So check it, treat it. And the other issue with vitamin B12 is remember that low normal levels are not optimal. We need to get it up over about 250 nanomoles per liter. And the reason for that is you can have tissue deficiency of B12 even before it gets below the current levels of usually 170 or 180. Folate deficiency. Folate and B12 work together in methylation reactions, so check and replace folate. Vitamin E, check and replace vitamin E deficiency. Vitamin E is a potent membrane-bound antioxidant, part of our mitochondrial cocktail. And also copper deficiency, which some people forget about. A lot of people get these hair, skin, and nails supplements, and you've probably taken, some of you might have. Hair, skin, and nails, what do they contain? Biotin and zinc. The problem with zinc deficiency is when you treat it and you don't give copper, you become secondarily copper deficient. So treat whenever you take zinc, check your copper and have a balance, usually about a 5-to-1 ratio of zinc to copper. So anyhow, simple things that can keep people out of trouble. But what are more specific mitochondrial strategies? I mentioned bypassing the defect. CoQ10 is the most commonly used compound. Succinate and riboflavin have been tried. Not as much evidence for them. People have tried reducing lactate. Peter Stackpool, I saw earlier today, was doing some work on DCA. Problem is it can cause neuropathy, and so it really hasn't panned out. Antioxidants, again, the core of treatment for mitochondrial disease, especially for Leber's. Vitamin E, membrane-bound antioxidant. Alpha-lipoic acid, a potent antioxidant in the mitochondrial matrix. And the other issue is any antioxidant, if you only take one, eventually it can become a pro-oxidant. You need redox couples, so you can't just have one antioxidant, which is probably the failure of so many antioxidant trials, like even in Parkinson's disease, where people have tried CoQ10 on its own. People have tried giving antioxidants to smokers, and part of that failure is they're not giving couples, so you need to regenerate the antioxidant that you have. And so we like alpha-lipoic acid and CoQ10 because they're both inside the mitochondria. Idebenone really is just a shorter chain version. It was a modified version of CoQ10. And the reason is not so much about the blood-brain barrier, it's all barriers. What happened is the original formulations of CoQ10 were not well absorbed, so they didn't cross the gut and they didn't cross the blood-brain barrier. The newer formulations of CoQ10 are much better, and I can show you in our study in just a minute. They do get absorbed, and that's how idebenone was first created 25 years ago in Japan and Italy simultaneously, and it was to get a better absorbed formulation. But really the new CoQ10 forms are very similar. Alternative energy sources. So we've published a lot on creatine monohydrate, which is an energy shuttle from the matrix of the mitochondria to the cytosol. It also is an antioxidant, and it provides the cell with some energy. And there's a whole bunch of other reasons why it's beneficial in neuronal health. Exercise training, aerobic and strength training. We recommend that people do a little bit of both because there's benefits for reasons I don't have time to get into. And I won't talk about the other ones there because it's more MELAS relevant. So what are some of the challenges with mitochondrial therapeutic trials? The one challenge is small numbers of individuals and heterogeneity. So for example, with Leber's, do you have somebody who just went blind? Do you have somebody who's been blind for a year, 3 years, 5 years? What age, male, female? I mean, it starts to get so heterogeneous that it makes it a challenge. MELAS syndrome, it's even more difficult. The other challenge are open studies. So I love the fact that the original idebenone study was double-blind. And if something's not double-blind, I would say to all of you, it's not worth listening to because natural history is garbage. I know people don't like me saying that, and I know I'm going to get killed by the drug companies. The problem with natural history is people assume that people are doing the same things now than the cohort did before. It's a different country, possibly. It's a different state. It's difference in what people know. It's difference in what people are taking in terms of other supplements. You need a randomized double-blind trial to understand if something's working. Once it's been proven to work in a randomized trial, then you can do post-surveillance monitoring of people with open trials. But too many drug companies are using them, and that's just my bias, but it's true for so many diseases. So randomized double-blind trials. So another challenge that we've had is that some of the cocktails that people have done are redundant. So instead of targeting multiple final common pathways, people just heap more and more and more antioxidants on, as opposed to trying to target the pathways of antioxidants, that's that reactive oxygen species, providing alternative energy sources, things like creatine, CoQ10, succinic acid, and trying to improve electron transport chain flux. So we've proposed years ago in a paper in Annals of Neurology that because there's so many final common pathways of mitochondrial dysfunction, we need to have multi-ingredient supplements which target those pathways. And if you think about it, when I first started medicine 40 years ago, the survival rate with acute lymphoblastic leukemia was around 30-40%. It's now up over 85%. And the difference really is that they're using combination drugs to treat ALL. At least that's one of the strong reasons why that's the case. We did studies in the muscular dystrophy mouse called the MDX mouse, where we compared prednisone, which is the standard of care, to creatine, which we'd already shown was beneficial and equivalent and additive to the prednisone. But then when we used a multiple ingredient approach, we had about threefold the benefit, and that was published in Muscle and Nerve a few years ago. So what about mitochondrial disease? What's the reason why people have tried the mitochondrial cocktail, and what's the evidence for it? So this is a study from Barbara Marriage, where she looked at 12 patients. Half of them had Leber's. And what they did, it was again an open label trial. This was more just a proof of concept, where they did blood cells and looked at ATP production. And what they used was CoQ10, carnitine, B complex, including folate, vitamin K, it's so darn sensitive, and vitamin C, a cytosolic antioxidant. So what they found is that there was an improvement in what's called the ATP production. So they measured how well the mitochondria could make energy, and that improved quite significantly, but it didn't lower the lactate in the patients. Now, part of the issue there is most people who have LHON don't have elevated lactate, so it's hard to lower something that's already normal. But it does show that there was an improvement in ATP production. Again, it wasn't a clinical trial. It was looking at white blood cell levels, but did show some benefits from a cocktail. So given that there was no randomized double-blind trial published in the world in patients with primary mitochondrial disease, and I'm not bashing UMDF, but I came to their granting committee 3 times and got rejected. I used my own darn money I'm a clinician, so I threw some money into a pot, and I did this study. So this was a study with some of my grad students, and it was a true randomized double-blind study. So we had 2 months on therapy, 2-month washout, 2 months on placebo, or vice versa. Neither us nor the patients knew what they were on. So we had them on CoQ10, vitamin E, creatine, and alpha-lipoic acid. For the rationale I just told you, we wanted to target the multiple final common pathways. We had 16 patients with definite disease, genetically confirmed, including Leber's. And what did we find? The first and most important point, the reason why people went to idabeno and they went to Epi 743 is that the original formulations of CoQ10 did not get well absorbed. So this is the, Raj, I forget his, Chopra, trying to remember the company that made the CoQ10, but you can see clearly here that we did get good absorption, and our plasma levels went up almost 3-fold. So we were absorbing the CoQ10 in our patients, and then we measured 2 markers of oxidative stress. So this is a marker of DNA damage called 8-hydroxy-2-deoxyguanosine. It went down. This is lactate. So lactate is an indirect measurement of improvements in mitochondrial efficiency. And the patients who had elevated lactate, this did normalize, and that was stat significant, as were the reductions in oxidative stress marker of lipid damage, which are called 8-isoprostanes. Now, again, it was self-funded, so we couldn't carry this on for years and years and years to look at quality of life and other things. But it did show that the canonical markers of mitochondrial disease were favorably enhanced by this mitochondrial cocktail. So again, everybody criticized me and they said, Mark, come on, drug companies, you got to identify a target, you got to come up with one drug, and that's the way we do drug development. Mark, don't you know that? And I said, okay, well, let's ignore everything that we know about the rationale behind the multiple final common pathways, and let's just do CoQ10. because everyone thinks CoQ10 is the second coming of Christ. It's the only thing that's going to work. So what we did is I said, okay, and I again saved up some more money because no one would fund it, but just to prove the naysayers, and again, randomized double-blind study, but what we used is only CoQ10. And we used massive doses, so 600 milligrams twice a day of coenzyme Q10, again, hydrosoluble Q-Zorb is the name of it. We had 30 patients. Again, we had some Liber folks. Geez, this is twitchy. And mostly MELAS patients. But we did MR spectroscopy, so we looked at a whole bunch of things in the brain. We measured cycle ergometry. We did lactate before and after cycle exercise. And what did we find? Nothing. So unlike our previous study where we showed consistent reductions in oxidative stress and we showed reductions in lactate, we didn't see any of that when we just used CoQ10 on its own. A little bit of an improvement in cycle ergometry, but we had to kind of, go to quaternary outcome measures. It wasn't our primary outcome. And in the brain, too, we really didn't see anything. There's no lowering of lactate or anything in the brain. There was just a little bit of a drop in choline compounds, but nothing really that significant. So again, I won't go into this, but this is the canonical first study by Dr. Klopstock from Germany using idebenone. And again, you're all familiar with this study. It didn't meet its primary endpoint. So one of their secondary endpoints, which were the patients that had a discrepant visual acuity at baseline, did show a stat significant difference, but showing a benefit with idebenone. Now keep in mind, this is a placebo. So I almost think it would be unethical now to give someone a true placebo where you're on absolutely nothing. And I don't think too many patients would say, well, given all the evidence that we know now, would you truly go on a placebo? But remember, a true placebo versus, CoQ10 essentially, it's almost certainly going to be of some benefit. And in the real world, does this actually work? So this is the paper that came out just a few years ago, which we had hypothesized there was going to be a recessive form because we had a bunch of patients where two brothers had it, and we sequenced their mitochondrial genome, and it was normal. We did whole exome sequencing, and we missed the DNA JC30 variant, but this group found it. And what they did is in the autosomal recessive form of Leber's, they looked at their patients who had the mitochondrial DNA inherited form versus the autosomal recessive form. Jesus, this is twitchy. And what they found is that the autosomal recessive form tended to have more spontaneous recovery, and there was an even greater benefit from taking the idebenone. So what you see here is about a 43% recovery in the traditional Leber's patients who were treated with idebenone versus only a 30% in those who, oh my goodness, who weren't treated. Anyhow, sorry about that. I like to show things with a pointer. So overall treatment, we generally put our patients on the full mitochondrial cocktail, and I can give you the doses of that at some point for 18 months, because it's usually that 18 months after you first lose vision that you have the greatest propensity for recovery, and then we cut it back to a half a dose just from a compliance perspective. We give our patients Vitalux with zeaxanthin just to provide a bit more antioxidant protection, and I'll show you also some studies that we're doing which show that some of these things could be beneficial. We identify and replace deficiencies, and I've told you which those ones are. We tell people to avoid sunlight. Now, we're working on the paper, and I hope that all of you will respond and help, because we found that many of our boys, when they were going blind, it was in the summer solstice. It was plus or minus 3 months of the summer solstice. And so we came up with this hypothesis that maybe it was the UV radiation, which was one of the triggers, which kind of makes sense, right? If smoke's a trigger, UV radiation causes oxidative stress. So we got an ethics approval. We sent out stuff to folks all over the world. And do you know what our response rate was from the community? 2%. So please, if we send it out, because you can't conclude anything from a 2% response rate, but we do believe that sunlight is likely a trigger, and it's low-hanging fruit to just watch out for your eyes, wear a cap, and wear good sunglasses. Smoking, of course, Patrick Chinnery and others have clearly shown that smoking is a trigger. Sorry, being a Canadian, that we're giving you guys all the smoke from Canada, but wear an N95 mask. It's estimated that 85% of the smoke will be filtered out with an N95 if it's really smoky. Sorry about that from Quebec. Now, one thing that's really important is identification of people at risk. Again, people are saying, well, it might only be 15%, maybe even a few less than that, who may be at risk if you're carrying it, but you haven't gone blind yet. But still, even if it's 1% of people, when I look at how it changes people's lives, and I don't have to tell you about this, but when I look at what our boys and girls go through when they lose vision, I mean, it's life-altering. So even if there was a 1% risk, I think if the therapeutic strategies to prevent it are not toxic and not very expensive, it makes sense to try and prevent. As your grandmother said, an ounce of prevention is worth more than a pound of cure. We also recommend regular eye checks to see a neuro-ophthalmologist, because if you throw glaucoma on top of an already compromised nerve, that's not a good thing. If you throw cataracts on top of a vision that's not working very well, that's not a good thing. And many of our patients actually do develop cataracts with mitochondrial disease, and throwing a cataract on top of someone with a central scotoma, I'm sure, it's not a good thing. So make sure your eyes are checked. ERT at menopause, little controversial, but I do think that that's something to consider, because most of the women we see, it's usually in their 40s and 50s when they're going through menopause. So does prevention make a difference? We're still working on this paper. Essentially, what we've done is when we identify one person with Leber's, as was pointed out, there's usually a whole plethora of people who obviously have the variant in that family. So we've identified and followed a number of these people. So we have what are called patient years. So we've followed 2,184 patient years of exposure. So that's all of our patients that we have identified from the time the proband, or the person that was first affected, was seen. We identified other people that have the mutation, and we've followed them now for my 28 years of practice. So taking an average life expectancy of age 84, we expected that we'd see about 14.3 cases of those individuals going blind, and what we had was 2. So our expected versus what we observed is much lower, and these are people following our guidelines to don't smoke, all of the stuff I told you about, the sunlight, and we also put people on the low-dose mitochondrial cocktail. So low-dose CoQ10, lipoic acid, vitamin E, and low-dose creatine. Now, why did our 2 people go blind? Well, the 2 boys who did go blind didn't listen to me. So this is essentially healthcare delivery, is you just tell people what to do, but in reality, some people won't listen to you. So unfortunately, 2 of the boys, one 18, one 19, they were actually brothers, came back and went blind. They were rather defiant, and they went out party, didn't listen to any of our guidelines, and both of them unfortunately went blind. They have the 3460 variant. So I'll just finish with what we're doing now. Right now we are doing a project funded by Mito-Canada, where we're comparing idabenone to the mitochondrial cocktail in LHON fibroblasts. We have some funding from UMDF, most of it's coming from Mito-Canada, and in vitro, which takes quite a bit of work to get these cells working properly. As we just saw, in vitro work's a little bit of a challenge, but we now have it up and running, and we use all sorts of inhibitors to inhibit complex 1. We're zapping them with essentially sunlight with UV radiation. And can't give you all the bottom line, but we've discovered, I think, a potentially brand new area, a complete paradigm shift in how we're going to treat mitochondrial disease, which hopefully I can talk to people about next year. And we've got a supplement that we think would work well. And we're working on coming up with a better multi-ingredient supplement. So we were approached because we discovered this interleukin-15, which stimulated skin, by a skincare company to license our patent. So I said, well, you can't use IL-15, but maybe I can come up with a supplement that would do something similar. So this is a publication that you can see there. It's published in Cosmetics, which now has an impact factor, and it's on PubMed. One of our postdocs did this study. So what we did is we had older adult fibroblasts, because older people have mitochondrial dysfunction, and we cultured them with alpha-lipoic acid, CoQ10, vitamin E. That's our mitochondrial core. But we wanted to see if adding a few other things would be beneficial. So we added vitamin C, D, E, biotin, astaxanthin, lutein, zinc, copper, curcumin, and resveratrol, pretty much everything that's been shown to improve mitochondrial function. And what did we find? So we cultured their cells, and you can see across the bottom there, that's complex 1 through 5, which are the 5 complexes of the mitochondria. And what we've done in light bars is the control media, which has got some amino acids and sugar. The brown bars are cultured with that supplement as well. So you can see the brown bars are higher across the board. What it showed is for complex 1, 2, 3, 4, and 5, there was a much higher amount of mitochondria and mitochondrial activity when they were supplemented with the supplement versus a placebo. So this is mitochondrial biogenesis, making more mitochondria. But the other interesting thing, if you look at the far right there, that's called manganese superoxide dismutase. Manganese sod is the endogenous antioxidant that's in your mitochondria, and that was much higher on the supplement. So we induced endogenous antioxidant protection, which is a little bit paradoxical because we gave exogenous antioxidants. We were worried that that was not going to do anything or even go down, but it actually went up, which was a bit surprising. But also on the far left, you can see glutathione peroxidase, which is another antioxidant, which also went up, which was encouraging. So I'll finish that with all the folks who've done all the work in our lab, and particularly want to do a shout out to Dan Wright and family. Dan was the chairman of the board at UMDF, and he's funded a bunch of our research. UMDF has funded work, Mito Canada has funded a bunch of our work, and the CIHR. So thanks very much.
I hope you enjoyed that treat of so many years of experience of caring for so many LHON patients. I learned a lot. I hope you all did too. We're at the end of the time for our session, so we're going to not take questions as a group. We will just wrap up and take a half an hour break and come back at 4 o'clock for the next session. But you can, I believe, be around during the break and take some questions for a few minutes, hopefully.
Could we do 10 minutes? If those want to stay. I mean, it's only coffee.
You're in charge, Maria.
Oh, absolutely, yes. Sorry, didn't know you were talking to me.
I did.
Yes, I say questions if they are willing to stay.
Oh, okay, sure. Microphone people, Mary.
Yeah, 'cause it's hard when you're like drinking coffee.
Yeah, I can't see you.
Hello? I think it's on now. Maybe not. Is it ready?
Mics, and then I think also state. We're good?
Hello? Okay. Hi, I have a question for the doctor. I have two questions, actually. The first one is when you talk about low doses of idebenone, I know we start out by taking the 900 milligrams daily, 3 times a day. What is a low dose that you're recommended for the long haul?
For me?
We don't use it.
Yeah, well, I stick to the same. I don't give low dose. I stick to the literature. I dose it per weight in a smaller child, but I stick to the literature. Like I give the 300 3 times a day.
Okay. But the doctor who just presented said that he gives a cocktail, and he says he gives, discussed a low dose.
So we use the CoQ10 lipoic acid creatine vitamin E instead of idebenone for a whole host of reasons. I mean, biochemically it makes a lot of sense. Number two, in Canada we can't actually get it. So I mean, people can pay for it, but unfortunately a company bought out the rights in Canada even though it wasn't on patent and jacked the price up by 45-fold. So practically it's just not an issue. But what we're finding is that our efficacy is great in terms of our outcomes. So what we do is we use, if you go on our paper, we have 200 milligrams of CoQ10 twice a day, 200 milligrams of alpha lipoic acid twice a day, 400 units of vitamin E twice a day, 100 milligrams per kilogram, up to a maximum of 5 grams of creatine once per day, and then we just cut that in half after 18 months.
Okay, thank you. The other question that I have is about the ferritin levels. At the same time that I was diagnosed with LHON, I was diagnosed with hemochromatosis, and my ferritin level was sky high. So they brought it down, but they want to keep it like, in the 40s, 50 range. Is that too low? I think it's 45 to 65 is where it's at.
Yeah, hemochromatosis is a unique situation, but as long as you're not driving it down to 6 or 7, you're fine. But hemochromatosis therapy is exactly what you're saying. You bring it down to normal levels. So you've taken your high level back to a normal level. If someone was at 6 or 7, which we often see in our patients, especially young women, then we like to see them over 50. But hemochromatosis is much more of a challenge for men because they don't have a period, so they're more at risk. And it's easily identified. If your ferritin is over 400, then chances are you have hemochromatosis if you're Caucasian.
Okay, thank you.
Hi, I also have 2 quick questions. The first one, and Dr. Dairi, I apologize if I'm mispronouncing your name. When you're giving idebenone to your patients, that was kind of my question, was back when Terry was diagnosed, we were looking to see where we would even get our hands on it. And, it was like one company where you could buy the supplement through. So I was just curious where you're finding it available for your patients. And then my second question would be for that cocktail. I know that you said you initially started with 18 months, but do you recommend patients actually staying on it longer than that? Or, is there a time limit, I guess, for that cocktail?
Go ahead.
So NANOS is a North American Neuro-Ophthalmology Society. They actually have a webpage for where to find idebenone that they keep updating. So I have it as a smart phrase that I give out to my patients. There's multiple resources, and sometimes, it gets outdated by a month if some company decided to drop it, and then they update it later. There's Dr. Sadoun. Many of you may have heard of him. He actually tests the true concentration in those supplements because they're not FDA approved and therefore they're not regulated. So he would approve whether they're good or not.
Yeah, so we go with the full high dose of the mitochondrial cocktail for 18 months, and then we drop down to 50%, which is still a very potent antioxidant cocktail. But just from a very practical perspective, if, as we want people to stay on it for the rest of their lives, we were finding that a lot of people taking, all these medications twice a day, a lot of folks would just become less compliant. And so we simplified it and dropped it down. And we still can see in the blood that we get significant reductions in oxidative stress, and lactate stays low in our MELAS patients, where it's they're much more severe and the lactates are much higher. But in Lieber's, like I say, the dropping to 50% allows people that long-term compliance. And we find this a lot easier to take the simplified version. And the big benefit we generally see is in the first 18 months after visual loss. I mean, that's where there's a lot more oxidative stress and the initial damage is going on. But we haven't had a single patient who has had visual loss have any further deterioration in function in 28 years using that strategy. And as I say, the only 2 people who in our entire extended cohort who had visual loss in 28 years were those 2 boys who stopped everything, and unfortunately they both went blind. But they were partying and smoking and just everything you shouldn't be doing. Yeah, it was really sad.
One more thing, I just remembered, I do have a patient, it's a child, who actually got a second opinion at the Children's Hospital of Philadelphia with a geneticist who managed to get her the idebenone paid by insurance. You hear me now? Yes. Yeah, I do have one patient who saw the geneticist at the Children's Hospital of Philadelphia and managed to get the idebenone paid for by the insurance. I haven't figured out how to do it, but they were able to do it for her.
Are you saying the first 18 months from onset, taking the full course, or take it for 18 months regardless, as, like, let's say you've had it for 2 years like myself, it affected would you start off with the full dose for that first 18
Yeah,
months?
I think for everyone, when you get the diagnosis, whether it was from your initial loss of vision or, once you get diagnosed, if it takes 2 years to get the diagnosis, I think it's always worth doing the full cocktail for 18 months. It's sort of like what we call a prime constant infusion. So you get up to your level and then you stay on a maintenance. And also, it's the triggers that I think are the biggest issue. Making sure that you're blocking yourself from excessive UV sunlight. Smoking is the most, probably the most consistent stressor, which makes a lot of biochemical sense. Drinking, everyone says no drinking, and I'm not telling people to drink, but the problem is a lot of our patients won't even take a sip of wine. They won't even take a light beer. And we did a study, and this is again with OPA1 patients mainly, where we had many dozens of patients that we followed, and we published this a few years ago. And we found that it was only quite excessive drinking that was neurotoxic. So unlike methanol, which is very damaging to the nerves, we were thinking that even 2 or 3 drinks a day was going to be damaging to OPA1 patients. That's optic atrophy type 1, which is a mitochondrial issue as well. And we found that it was a huge amount of alcohol was necessary. So essentially, we relaxed the recommendations on our patients to say, look, if you're at a dinner tonight, a glass of wine, no one in the world can tell me that that's going to cause damage. If you have a beer tonight at dinner, that's not going to cause damage. But we strongly advocate that obviously people don't excessively drink. And for those who have drinking problems, of course, never touch it, because once you start a little bit, you're going to take too much. So smoking, I think, is the biggest issue. We're hoping to show that the sunlight is an issue. We're doing this in vitro, and hopefully people will give us a better response to our send out. We're simplifying it, and we're using bigger font. So if you get our study, please send it back to us, because it'd be interesting to see if that was the case.
If you've been taking idebenone for the last, whatever it is, year or two, are you advocating to replace that with coenzyme Q10 and your cocktail?
Yeah, we started this for a very practical reason, because we couldn't get it. So patients, when the price went, I'll take a step back. For Friedreich ataxia, 20 years ago, we were using idebenone, and there was some studies that came out, and I was actually the one that approached the Inherited Metabolic Disease Program in Canada and got it approved for our patients. The entire program was being funded for X amount of money, but then a company came in, they essentially bought the rights to it, and then they went to Health Canada and said that you have to use our product. So there's a company in the States that was making it. Then they were forced to use this new product, but the price went up by 45-fold. So that would have pretty much broke the entire program in Ontario. So nobody could afford it, so they had to pay out of pocket. So the same thing was true of our mitochondrial patients with Leber's, is that in Canada it's 45 times more than CoQ10, the cost, and so it just was not being covered. So a few rich people were buying it, but biochemically, and based on our studies in proven mitochondrial patients, including Leber's patients, the canonical aspects of this disease are favorably enhanced by taking the cocktail as opposed to the idebenone. But again, it's a personal choice at this point. I'd love to go head to head, and I know Santhera will never do it, but there's just biochemically there's no reason why idebenone would be superior to a cocktail which is targeting the multiple final common pathways, especially given the data that we have. But we're doing it in vitro now. I mean, I can't give you the final results, but it's definitely supporting our hypothesis.
I have 2 questions. I've heard that there are some over-the-counter drugs that are not good for people with LHON. Do you have any information on that?
So I don't have a lot of information on that. What I found, like from what I've read, CoQ1 maybe over the counter is bad. If you're not vitamin B12 deficient and you're taking a supplement, maybe detrimental as well. There are certain antibiotics, and that's the most serious one, is just make sure that if you're going to take an antibiotic, you let your primary care doctor that you have LHON, and they have to go through the list whether or not you can take them.
Yeah, we have that list. I was just wondering if there were any other things that would cause, like an Advil or anything like that, that were problematic.
Yeah, from what I read, only CoQ1. Again, there was something else. Ubiquinone. CoQ1, ubiquinone, oh no, ubiquinone hasn't been proven, I'm sorry. CoQ1 and cyanocobalamin if you're not B12 deficient.
Thank you. My other question is, you know, as we get older, we're on other prescription drugs. Do any of those, like cocktails that you talked about, cause any issue? Or is that something we just have to discuss with our local physicians?
So there's several things there. Number one, one of the most common drugs prescribed in the world are statin medications. Statins block CoQ10 synthesis. So if you are on a statin, you should be taking coenzyme Q10 because when you block HMG-CoA reductase, you will block CoQ10 synthesis. So definitely, if you're on a statin, you absolutely should be on. Now, for the average person, no, but if you've got mitochondrial disease, Dr. Vladechu and I and others have published people unmasking their disease by going on a statin medication. So I would definitely recommend that. Number two, Advil, Tylenol, you know, these medications, there's some evidence that they can inhibit mitochondrial function, but that's extremely high doses and not the 200 to 400 milligrams that you would get. So I would not have any issues whatsoever with anyone taking Advil. And in fact, many of our MELAS patients have severe migraines, and they take Voltaren Rapide is probably the best medication for their headaches, and there's no evidence that that causes any issues. The cyanocobalamin, the reason why, so it's not the cobalamin that's the issue, it's what it's paired with. So the cyano has some cyanide-like properties, which inhibits complex 4. So the only challenge and why you shouldn't take it is that you're only going to get that, you know those IV infusions that some people get? They get this bag of crazy vitamins from certain doctors that I won't mention. That's where I would strongly say do not get big doses of vitamins intravenously, because then you could get enough of the cyano component of cyanocobalamin that you could inhibit complex 4. So number one, be careful too, because if you keep throwing more and more and more antioxidants on there, you can actually make them a pro-oxidant. We did a study where we put all sorts of antioxidants into a gamish, everything that was pretty much known to mankind. And I was going to, kick my grad student. I said, dude, your data is showing that it's a pro-oxidant. And we did it 24 different ways to look at it, and it was a pro-oxidant. So we took these crazy things called antioxidants, and just because it's called an antioxidant, if it's not been studied in a human in the combination that you're taking, be careful. So, CoQ10, vitamin E, vitamin C, alpha-lipoic acid, creatine, all of those things have been carefully studied in not just this disease, but muscular dystrophy and everything. Idebenone, these are all, very safe medications in this disease. But, when you start going outside of that and taking things that, someone tries to sell you on Amazon, be very careful, because you just never know what that interaction is going to be when you take too many. The other issue too, and nothing against your slide, but everyone in the world thinks this, but we had a big debate about this on Metabel. Ringer's lactate, oh my goodness, drives me to drink. Ringer's lactate was created to buffer protons. So what happens is Ringer's lactate does not have acid in it. It actually was designed to pull acid out. So anyhow, but you guys won't be prescribing Ringer's lactate. But anyhow, everyone eventually agreed with me on Metabel that yes, Ringer's lactate is not contraindicated in any mitochondrial disease. It does not cause lactic acidosis.
Oh, one more is people during COVID were taking zinc supplement. It could lower copper, which can actually be detrimental in LHON.
Yeah, that's what I was saying, is that, I don't know if it came across, but when you take zinc, be careful, because everyone takes it for their hair, skin, and nails. And, it has minor benefits there, especially if you're zinc deficient. But remember to take copper, because over a long period of time, copper deficiency causes a corticospinal tract involvement. You can actually get spasticity in the legs, not good. So usually it's a 5 or a 6 to 1 ratio of zinc to copper. So you can buy copper supplements, 1 to 3 milligrams. So always be taking 1 to 3 milligrams of copper if you're taking a zinc supplement. Don't get copper deficient. It's horrible. I've seen it 3 or 4 times, and it's not good. Question? Sorry. Oh, I didn't.
She's got the microphone.
Oh, sorry.
Oh, I wasn't sure. When you talk about the vitamin B12 and the cyanocobalamin, how about the methyl? We were told that the vitamin B12
The methylcobalamin, yeah, that's fine.
Yeah, the methyl.
Yeah, that's what I'm saying, is it's got nothing to do with the B12.
Right.
This problem is the cyano component.
So the methyl.
Yeah, methyl's fine.
Methyl's good. Okay,
Yeah.
all right.
Now remember, with vitamin B12, if you're taking vitamin B12, take folate as well. Because if you can unmask a folate deficiency and vice versa if you don't take 2 of them. Yeah.
Yep, he's bringing the mic around just a second. He's working his way around the room.
He's working the room.
Oh, yeah, to the back. Mary?
So it sounds like the treatments are most effective with people that are affected like 2 years or less. Is there any known effectiveness in people that have been affected for over 10 years? Because it sounds like most of the clinical trials only go up to 10 years.
Yeah, I think you're absolutely right. The studies do show, and if you look at the Klopstock study, I don't think there's anyone over 10 years, but it never hurts to try. There still may be some cells, in stroke, we call it the penumbra. So just at that sort of the area where they're still healthy and not healthy, there may be still some benefits. And keep in mind is that the longer you have it, if you've had it for more than 10 years, you are getting older. And we know that part of normal human aging is mitochondrial dysfunction. So things like macular degeneration, cataracts, all of those things are oxidative stress and more common as we get older. So I don't see any harm in, and that's why we always say go on the full dose for 18 months and then a maintenance dose. See if there's any benefit. Because I was a bit surprised if you look at the Klopstock study, some people that had visual loss for even 3-4 years were still getting some benefit. So we would definitely recommend trying, yeah.
So we've got the microphone here and a microphone there, and then we should probably stop after that and give people a chance to take a break. So go ahead.
Sounds good. My name's Richard. I'm from Colorado, and I have a niece and nephew who were tested, and they definitely have the gene as I do. And in Colorado, one of the main things that is very prominent is the use of cannabis or THC in the bloodstream. Has there been any what are the effects of this with use? I'm looking at their longevity and what uses or the abuse of THC. What can that do to individuals who carry the gene?
Yeah, first of all, smoking dope, I would freak out on my patients if they did it. It's no different than smoking tobacco. It's the combustion that's creating the compounds that are inhibiting complex 4. So if someone smokes like crazy and they can get off it by vaping, I'm a little bit better with vaping than smoking, but nicotine still can have some deleterious effects on the mitochondria. And the same's true of smoking marijuana. So absolutely no smoking. If you're really you absolutely had to take it, because the kid's hooked on it, whatever. Vaping would be your next best option. However, Dr. Johnny Parisi has got some data that will be coming out soon showing that the THC itself is mildly deleterious to mitochondrial function. CBD is not, THC is. So CBD does not seem to have the deleterious effects. So if someone was eating a CBD gummy, I have not seen any evidence that would be deleterious. But smoking dope, same as smoking cigarettes, that's the worst thing you could do.
Thank you very much.
Eric?
Hello?
Yep.
Where could you find the cocktail that you were mentioning? You mentioned your paper. Just a quick question there, and I have a sunlight question.
Yeah, so there's been concern about nutritional supplements in general. In Canada, we have what's called the NHPD, and so I know because we are selling a supplement for obesity and fatty liver disease, and so through NHPD in Canada, we have to be within 3% of label claim. So our stuff is tested, and we have to keep retesting every year to make sure what's on the shelf is within 3% of label claim, which is a pharma type of approach that we have in Canada. Such is not the case in the US. I can tell you in the US, however, that we've tested blood in people who've taken CoQ10 from Costco and have taken vitamin E from Costco and vitamin D from Costco. And all of them raise blood levels in the way that you would expect. But to some extent that makes sense because Costco's not stupid. They have incredible buying power and they're buying from GMP facilities. So we're quite confident that the vitamin E, the coenzyme Q10, and I don't think Canada's any different than the US in terms of where Costco buys it from, is sufficient, as is vitamin D. Now, alpha-lipoic acid in Canada, we have a few reputable companies that have GMP manufacturing facilities, and we recommend that people buy them. One's called Swiss Herbal, and the other one's called Jameson, and we know that it's made in a GMP facility, and it has to be within 2% of label claim. So again, go for the reputable companies, because these are the folks that are buying generally from a GMP facility.
Okay, thanks. And what did you mean by avoid sunlight? Like avoid sunlight against your eyes? Avoid, like you meant like around your
so
skin?
for sunlight, we know that exposure to sunlight increases your risk for cataracts, macular degeneration, and we know that sunlight, we've done a lot of work on radiation, causes damage to the mitochondria and it causes oxidative stress. So generally what we recommend is that people wear UV protection sunglasses. So don't buy cheap garbage things from a corner store, but Oakley or something that has UV protection. And generally what we recommend, which I've noticed when I hiked in the Sierra Nevada mountains, is wear a cap. It's just low-hanging fruit to keep that the sunlight directly out of your eyes when you're walking. So that's what we generally recommend to our patients to avoid the deleterious effects of sunlight.
I think my impression is this could go for a very long time because this is so, maybe I'm on the wrong mic. Push a button. Okay. Yes. Thank you again so much.